Along with bronchodilators, ICS, your inhaled corticosteroids, forms the second arm. This is considered your anti-inflammatory drugs, which are controllers. Corticosteroid serves as the prototype for your controllers. According to the GINA guideline, the use of a steroid with a LABA combination spans all steps of the management from your well controlled to your very poorly controlled asthma. The addition of your combination steroid with formoterol is a recent addition. In the past, step 1 treatment was allowed to be managed with short acting beta agonists alone, with or without an inhaled corticosteroid. The current guidelines reviews the reasons for adding the recommendation of an early ICS formoterol recommendation will be that patients who are actually mild in their classification are at risk of serious adverse events. 16% of patients with near fatal asthma had symptoms less than weekly. 15 to 20% of adults dying of asthma may have very mild symptoms less than weekly in the last 3 months. Exacerbation triggers are known to be variable, whether it is viruses, pollution, or poor adherence, but your the use of SABA as a first line of treatment for the many years in the previous recommendations was bolstered by the fact that asthma was thought to be primarily a disease of bronchoconstriction. Today, the understanding of the role of inflammation as the central cause of all the hallmarks of your asthma is now better understood, and studies will bolster this recommendation. Our understanding of asthma is evolving. Previously, it was an episodic acute inflammation that happens throughout your life. But what they're seeing now is that frequent recurrence may lead to chronic inflammatory changes, thickening of the smooth muscles, hyperplasia of the mucous glands, and general airway remodeling can lead to permanently dilated bronchioles. Steroids will help prevent the progression and decline in lung function by decreasing this propensity for airway remodeling. Being lipophilic, corticosteroids can readily enter into the cell and bind to glucocorticoid receptors in the cytoplasm, which can translocate to the nucleus. Here, the glucocorticoid and receptor homodimer binds to your glucocorticoid response elements, which are in the promoter region of steroid sensitive genes. Here, they may have twofold effects. One is to repress secretion of anti inflammatories, proteins such as your annexin, your serine leukoprotease, your mitogen activated protein kinase, your glucocorticoid induced leucine zipper protein. All of these are anti inflammatory. But the other side of it will be it can also repress the secretion of pro inflammatory cells, proteins. And by binding to a portion of the activator uh, protein, which is your cortisol response element binding protein or CBP, you can decrease the amount of cytokines, chemokines, adhesion molecules, and inflammatory enzymes, receptors, and proteins. Steroids will not only arrest the release of pro-inflammatory cells. It will also preserve the integrity of the structural cells that are normally affected by inflammation. The integrity of your epithelial cells is preserved, a decrease in endothelial cell vascular permeability. There is a decrease in the activation of airway smooth muscles and a decrease in mucus hypersecretion resulting from the steroid effects. There are many inhaled forms of your corticosteroids, the oldest of which is your budesonide and fluticasone. Newer steroids will be your ciclesonide, which is a prodrug, your mometasone, and beclomethasone. From this table, you'll see that each inhaled steroid has specific properties. We'll note, for example, that your volume of distribution is highest with fluticasone because of its lipophilicity. Comparing that with your budesonide, however, your budesonide may still retain a long duration of action because of a different mechanism, which is active intracellular esterification and deposition with prolonged release of the drug through lipolysis. Now, what is important to note is that although these properties can vary, your clinically equivalent doses which achieve the same effect have already been studied and recommended by GINA. We can look at this table in the next slide. GINA will tell us that there are several low, medium, and high doses, and although these may vary according to the different preparations, this these doses are equipotent, which means that they will achieve their effects for low, medium, and high at different dosages, but with equal potency. So the question is, which of these are more effective than others? According to the recommendations, as they are used according to their specific doses, they are equally capable of inducing these effects. From the table, you will see that ciclesonide has a significantly lower dosage, which produces the same effect compared to the other steroids. The difference is that ciclesonide is activated within the lung by your airway esterases, and therefore it escapes your conversion and it is safer in transit through the oral cavity, GI tract, and liver. In the systemic circulation, it causes minimal effects because it's 99% protein bound. Once it reaches the lung, it is then activated to its active metabolite, this isobutyryl cyclesonide. There are also recommended doses for children 6 to 11 years, which will differ from adults, but the reminder will be similar. What may be a medium dose controller for one child may already be equivalent to a high dose for another child, and therefore, the individual variability in the response to steroids should be considered when uh, using the doses. The big concern with the use of steroids will be its adverse effects. If you're using inhaled steroids, however, the main concern will just be the local effect of oropharyngeal candidiasis, or commonly known as thrush, which you can easily avoid by asking the patient to gargle. High doses, however, even if it is inhaled, may also produce the systemic effects of uh, water retention, increasing your blood pressure. This is partly due to your aldosterone like effects of sodium retention. There are also effects related to your hypertension, your congestive heart failure, thromboembolism, and thrombophlebitis. The typical features will relate to your Cushingoid features, which will include your moon fascie. Redistribution of fat centrally will produce your buffalo hump and central obesity. Your The presence of peptic ulceration, increased appetite, relates to the steroidal nature of the drug. Muscle weakness, osteoporosis, and hirsutism will be related to the relation of your corticosteroid structure to your gonadal hormones, your testosterone. Closure of the epiphyseal plates will produce growth suppression in children. These are the concerns that limit the use of many steroids. The inhaled route is the standard therapy, but in acute exacerbations, it may be warranted to start with an oral or systemic steroid. In the treatment guidelines of GINA for emergency room management, it is recognized that prednisolone in doses of 1 milligram per kilogram may be needed to stabilize the patient. While this is given, an inhaled steroid is started so that there is an overlap. As your systemic steroid is tapered, your inhaled steroid will reach its peak effect in a week to 2 weeks. You will need to review your lectures on the use of steroids. Recall that your hydrocortisone is a short acting, while your prednisone and solumedrol are intermediate acting. Long acting will be your dexamethasone. The greatest mineralocorticoid effect will be with your hydrocortisone and decreasing as you increase your potency of the medications. Dexamethasone is least used because of its very long acting action. Remember that exacerbations of your asthma are sometimes self limited and short lived. The next group will be your ICS and long acting beta agonists. ICS combined with ALABA produces a synergistic effect. 1 plus 1 equals 3. These studies have shown that the ability to control your FEV, to correct your FEV1 is superior when the combination of an ICS and LABA is given compared with a single agent given alone. Examples of LABA ICS combinations include the traditional combination of your fluticasone solmeterol with your budesonide formoterol and fluticasone formoterol. The three are approved for use in COPD, while the newer preparations, such as your fluticasone vilanterol and mometasone formoterol, are under study for use and COPD, although they are established for asthma. We've talked about the benefits of combining your steroids with your LABA, but we should also be aware that there are adverse effects that are compounded when you combine your ICS and LABA adverse effects. Extensions of your beta agonist effects will carry over, including the nausea, vomiting, tachycardia, tremors, arrhythmias, and allergic reactions. For increased doses, hypokalemia. ICS effects are noted in the studies to be more often related to higher doses and longer durations of use. In a study on the review of efficacy, adverse effects were noted with ICS LABA combinations only after a year of maintenance. Some of the ICS effects are local, sore throat, but others include the systemic effects of skin bruisability, growth retardation, peripheral edema, which may be related to fluid retention and hypertension, and immunosuppression leading to an increased risk for infection. Among the potential effects, the incidence of pneumonia is slightly increased with the use of fluticasone formoterol compared to its other uh, ICS combinations, and this can be again related to the increased lipophilicity of your fluticasone, which allows it to stay longer within the airways. Note that many of the local effects of your ICS may be avoided by simply instructing patients to gargle after use. In the guidelines, long acting muscarinic antagonists, or LAMA, are only added as an adjunct to the usual ICS LABA combinations. Your Diotropium is the prototype for your LAMA. Its ability to bind with higher affinity to the M3 receptors accounts for its longer action. It has an affinity that is 100 to 200 times greater than the SAMAs, and this is the mechanism by which it achieves bronchodilation. But in the same way that it is a sympathomimetic agent by antagonizing your muscarinic receptors, anti-muscarinic effects will extend and cause adverse effects, including your drying of secretions, constipation, tachycardia, mydriasis, and urinary retention, all of which are related to the sympathomimetic syndrome. Eukatriene antagonists are sometimes called your steroid sparers. By adding an adjunct eukatriene antagonist to your inhaled corticosteroids, you may reduce the dose of your steroids. Eukatrienes are generally implicated in all phases of the asthmatic attack. It is implicated in the recruitment of your ma- inflammatory cells ranging from your eosinophils, macrophages, your eosinophils, and mast cells. It is also responsible for nerve activation, your endothelial plasma leak, smooth muscle hyperplasia, mucus hypersecretion, and epithelial shedding. There are two types of anti-leukotriene agents, one which works more proximately in inhibiting arachidonic acid breakdown. This is your 5-lipoxygenase inhibitor known as your Xyloton. More distally, your cystenyl receptor antagonists will act on blocking the receptors to your leukotriene D4, which to reverse the bronchoconstriction, mucus production, and inflammation, which leads to asthma. The main question will be whether the more proximal 5-lipoxygenase inhibitors, which will effectively decrease the effects of all downstream leukotriene agents, will be responsible for producing all the other leukotrienes. Will that be more effective than the receptor antagonists? Xyloton is the prototype of your 5-lipoxygenase inhibitors. Its use is mainly in the prophylaxis and chronic treatment of asthma for patients greater than 12 years of age. So remember that these cannot be used for moderate to severe asthma, and it is not effective for the acute treatment of an exacerbation. Your 5-lipoxygenase inhibitor is equi- equivalent in efficacy to your leukotriene receptor antagonist, but it is less commonly used because of its adverse effects, which we will see in a while. Eukatriene receptor antagonists will inhibit the binding of your leukotrienes, and the typical agents will be your montelukast, pranlukast, and zafirlukast, which are used for intermittent to mild asthma or occasionally with persistent asthma. Like your zafirlukast, it is not effective in acute exacerbations or more severe asthma. This is the agent that is added to oral or inhaled steroids to decrease the dose of your steroids. And your montelukast is the only drug approved for use in children 6 to 12 years old. Eucatriene receptor antagonists work on the inflammatory reaction, and therefore they are of no benefit in COPD, where the pathologies are more irreversible and permanent. Your montelukast is an alternative treatment for allergic rhinitis, but its effect is generally less than inhaled steroids. Therefore, it cannot be used for moderate to severe asthma, and it requires monitoring for hepatic toxicity. The latest GINA asthma guidelines poses a warning for your use of montelukast because it induces suicidality in adults and adolescents and nightmares and behavioral problems in children. So if you're using this for a mild rhinitis, these risks can limit its efficacy. The leukotriene pathway inhibitors are actually well tolerated. There is minimal effects on headaches and increased alteration of liver transaminases, but generally there are few reports of chest pain, dizziness, fever, insomnia, some muscle pains, arthralgias, abdominal pains, weakness, conjunctivitis. Rarely the neuropsychiatric events of agitation, aggressive behavior, anxiousness, depression, hallucinations, irritability, suicidality, and tremors have been noted. Xyloton has a higher risk of Churg-Strauss vasculitis and therefore is limited in use. Despite all of these available treatments, both your controllers and relievers, a subset of patients, about 3% of patients, will have severe, difficult to treat asthma. And this is where your step 4 and 5 types of management will apply. Your In these patients, higher dose corticosteroids can be combined with biologic management. The use of biologic agents are limited for patients who have not responded or are recalcitrant to your usual high-dose ICS management. There are three biologic agents added for recalcitrant asthma, but these are chosen according to the asthmatic phenotype. Anti-IgE agents are used for asthmatic and allergic types of severe asthma, while your anti-interleukin 5 receptors and the most recent anti-interleukin 4 receptor antagonists are limited for severe eosinophilic asthma. Let's take a closer look at the markers that indicate their use. Patients who have severe allergic asthma associated with elevations of your serum IgE, a history of allergen triggered sensitization, which it may be documented by skin prick testing, with an exacerbation in the previous year, will be candidates for anti IgE therapy. The indication for anti-interleukin 5 and anti-interleukin 5 receptors will be severe eosinophilic asthma associated with blood eosinophils greater than 300 per microliter in an exacerbation in the previous year. Your anti-interleukin 4 receptors will be indicated for severe eosinophilic type 2 asthma with a recent exacerbation associated with blood eosinophils greater than 150 per microliter or a forced expiratory nitric oxide level of greater than 25 parts per billion, an indicator of the more severe types of eosinophilic asthma. The prototype of your anti-IgE antibody will be Omaluzimab, whose mechanism will be to bind circulating IgE, and the second mechanism will be to decrease the expression of high affinity receptors. The net effect will be to inhibit the binding of your IgE to the mast cells, leading to a decrease in the release of your inflammatory mediators, decreasing the symptoms and exacerbations of patients with allergic types of asthma. The ability of omalizumab to decrease your circulating IgE has been found to have benefits in eosinophilic apoptosis, decreasing receptors of IgE, and decreasing the mediator release. This has now been found to decrease the airway smooth muscle modification so that there is less of the hypertrophy and preservation of airway epithelial cells and decreased IgE synthesis. These benefits make it effective in moderate to severe persistent asthma in patients greater than 6 years of age who have a positive skin test or increased in vitro reactivity to aeroallergens for patients whose symptoms are not adequately controlled with inhaled steroids. The clinical benefits will be the elimination of seasonal variability in airflow and absolute reductions in symptoms and outpatient hospitalizations. The drawback of all your anti-IG, your biologics will be similar. They will cause injection site reactions, propensity for infections, the increased risk for anaphylaxis, and some risk for inducing cancers. Omaluzimab is a long-acting agent. Its administration results in a peak plasma level after 7 to 8 days, which lasts for a duration of 26 days. One vial will cost around 16,000, so that this is not This is an expensive mode of therapy which should be reserved for the most severe types. The prototype for interleukin 5 antagonists will be a monoclonal IgG1 antibody, mepolizumab. Its action will be to inhibit the growth, differentiation, recruitment, activation, and survival of eosinophils. It is a recombinant DNA technology produced from Chinese hamster ovaries. It is now known that the major secretions of your eosinophil, including your major basic protein, eosinophilic cationic protein, and various interleukins, can recruit not only your neutrophils but basophils, mast cells, macrophages, dendritic cells, and your T and B cell subtypes, including your plasma cells and platelets. What limits your mepolizumab use will be the common reactions in inducing infections. Like all the antibodies, it can induce hypersensitivity reactions. Headache is very common, as with nasal congestion, abdominal and pain, eczema, administration or site reactions, and pyrexia is common. An alternate agent to mepolizumab will be your reslizumab. It is an humanized IgG4 monoclonal antibody to your anti-interleukin 5 and shares the mechanism of inhibiting the maturation, activation, and survival of eosinophils. Reslizumab will have the same potential for adverse effects, including elevations of your CPK enzymes, oropharyngeal pain, myalgias, anaphylaxis. Benralizumab is a recent addition to the biologics. You can remember it by saying Ben-RA. Benralizumab binds to receptors and causes apoptosis, while other types of biologics will target the release of cytokines. It's only benralizumab that can cause apoptosis by binding directly to the receptors, RA. Benralizumab should be reserved for those with eosinophilic phenotypes who are not otherwise controlled by steroids and LABA combinations because of the increased incidence of allergies, which may cause anaphylactoid type of reactions characterized by fast heartbeat, hives, joint pains, and stiffness or swelling is also observed. With its long elimination half-life, your benralizumab is given 30 milligrams every 4 weeks for the first 3 doses, followed by once every 8 weeks thereafter. Clinical results will be the reduction in annual exacerbation rates for patients with blood eosinophils greater than 300 cells per microliter, and a change in the baseline FEV1 will benefit within the first 4 weeks and maintained until the end of treatment. From the name itself, dupilumab, you can see there is an IL. Dupilumab is capable of inhibiting interleukin 4 and interleukin 13, which has an effect on many cells, including your keratin. So it's used also for atopic dermatitis, which is resistant to steroids. Your eosinophilic recruitment is decreased, fibroblast secretion of your eotaxins, decreased IgE production, and decreased differentiation and survival of T helper cells. What is important with your clinical effects will be the preservation of the different cellular substrates, including your goblet cells, decrease in deposition of cellular matrix, proliferation of your smooth muscle cells is arrested, and decrease in eosinophilic activation, which has all the benefits of decreasing the other products of inflammation. Dupilumab is given by the subcutaneous route with a loading dose that is followed up by a 300 milligram dose every other week. Predictable adverse effects will include hypersensitivity reactions, skin reactions, unusual bruising, mouth sores, and a predisposition to oral herpes or other herpes simplex virus infections, inflammation of the cornea, keratitis, eye itching, and dry eye are also noted in the adverse effects. Overall improvements as well as specific parameters of decreasing your eosinophilic count and fractional excretion of your nitric oxide has been observed with the usual regimen every 2 weeks of dupilumab. In summary, various biologic targets may decrease the inflammatory responses that lead to severe asthma by inhibiting your IgE, your interleukin 4, and interleukin 5. Importantly, we have discussed the two major groups for the treatment of asthma, mainly the anti-inflammatory and bronchodilators, which in combination can provide appropriate prevention and treatment of exacerbations. Based on the pharmacodynamic and pharmacokinetic features, these drugs can be used safely, but monitoring of patients for adverse effects and efficacy is necessary.